Hello everyone, Dr. Mungli here. So in this video I will be explaining about folate and vitamin B12 deficiency, causes for deficiency, how to identify folate and B12 deficiencies, and what all the laboratory tests that we need to do in folate and vitamin B12 deficiency. Just as an introduction, so let's look at the storage of folate and vitamin B12 in our body. So the folate, which is also referred as vitamin B9. So note that around 3 to 4 months of storage will be there in our body for folic acid or folate. Especially it will be stored in the liver and other tissues. That is for folate. So folate storage in our body is 3 to 4 months. So compared to other water soluble vitamins, so there is a significant storage of folate in our body. Now coming to the vitamin B12, that is cobalamin. So cobalamin storage in our body is sufficient to maintain the needs of cobalamin for 3 to 6 years. Note that it is not months. So the amount of cobalamin that is stored in our body, it is sufficient to maintain the needs for 3 to 6 years, and the amount of cobalamin that is stored in our body, across our body, is around 2 to 5 milligrams. This is in milligrams. This is the total amount of cobalamin that you can find in the body, that is 2 to 5 milligram. In that 50% of this 2 to 5 milligram, it will be stored in the liver. So liver is the storage. It stores around 50% of total cobalamin that we have in our body. So that is sufficient for 3 to 6 years. It means, what is the RDA for cobalamin? So RDA for cobalamin is 2.4 micrograms. So the need for cobalamin is in micrograms. That is why 2 to 5 milligram is sufficient for 3 to 6 years. Okay, let's move on to see causes in brief. Now the folate deficiency, especially in the North American diet, so dietary deficiency of folate is very rare, because the food that people consume, so and also in any part of the world, if the green leafy vegetable is consumed, folate deficiency should not be seen. But why do you see folate deficiency in some people? And that's because of the increased demand. So say in a pregnancy, during pregnancy you can see folate deficiency because there is an increased demand during pregnancy. Folate deficiency can be seen because of overcooking of greens, overcooking of green leafy vegetables. If you cook too much overcooked green leafy vegetables, say in pressure cooker, so it's going to degrade folate, leading to folate deficiency. Or it can be because of intestinal malabsorption disorders. Intestinal malabsorption. So intestinal malabsorption for folate can lead to folate deficiency. Or it can be because of intake of certain medications like methotrexate. Methotrexate is an anti-cancer drug which inhibits dihydrofolate reductase enzyme, so thereby it leads to decreases the conversion of folate into tetrahydrofolate. That's an active form of folate. Now the folate deficiency can be seen along with the cobalamin deficiency, and that's because of folate trap mechanism. So about folate trap mechanism, I have another video on that, so you can view that. Link for that video is appearing on the right corner right now. Now let's move on to see cobalamin deficiency. So the cobalamin deficiency can be, and note that cobalamin is coming from food, from animal source, because the bacteria in ruminant animals particularly, they synthesize cobalamin and they accumulate cobalamin in their body. So the food of animal origin is the source of cobalamin. So cobalamin deficiency can be seen in vegans, people who are not eating anything that is coming from animal, including milk and milk product and eggs. So they can get into cobalamin deficiency. Or cobalamin deficiency can be seen in a disease called pernicious anemia. Pernicious anemia is a condition where there will be autoimmune destruction of parietal cells, because there will be antibodies against the parietal cells, and parietal cells are the ones which are responsible for synthesizing intrinsic factor. So intrinsic factor is used, means that is helpful in the absorption of cobalamin in the intestine. That's how deficiency of intrinsic factor in pernicious anemia can give rise to cobalamin deficiency. Or it can be because of atrophic gastritis. Atrophic gastritis can give rise to cobalamin deficiency because it will lead to destruction of parietal cells. Or it can be because of intestinal malabsorption again. Intestinal disorders where there can be destruction of terminal ileum epithelium, so where there will be cobalamin receptor, so that can give rise to cobalamin deficiency. Or it can be because of bacterial overgrowth syndrome, and the cobalamin deficiency can be because of gastrectomy also. Gastrectomy can give rise to cobalamin deficiency. Or it can be because of antibodies against intrinsic factor itself, or it can be because of congenital transcobalamin deficiency. So these are all the causes for cobalamin deficiency. Now let's move on to see signs and symptoms. So initial signs and symptoms of cobalamin and folate deficiency. Now the initial signs and symptoms of cobalamin and folate deficiency, they can be very non-specific signs and symptoms. So it can be generalized weakness. Patient may have generalized weakness. Patient may be feeling fatigue, and patient may have diarrhea. So patient may have confusion. So that kind of signs and symptoms, so which are very non-specific. So non-specific signs and symptoms can be seen initially. Later, the anemia signs of anemia can be seen in folate and cobalamin deficiency, and the kind of anemia that you see is referred as megaloblastic anemia. Megaloblastic anemia, so or it is a part of macrocytic anemia. Macrocytic. Patient will have macrocytic anemia, which is macrocytic anemia type is megaloblastic anemia. In macrocytic anemia, so basically there will be fewer red blood cells, but those red blood cells are big in size. Whereas the megaloblastic anemia, it is a kind of macrocytic anemia where there will be fewer red blood cells which are big in size, but also you can see overactive bone marrow, hyperproliferation of the bone marrow activity can be seen in the peripheral blood smear. That's a slight difference between macrocytic anemia and megaloblastic anemia. So this kind of anemia can be seen both in folic acid deficiency and cobalamin deficiency. So the anemia signs can be easy fatigability. Patient becomes fatigued for small little work easily. So there can be shortness of breath. Patient may have shortness of breath, so he won't be able to work for a long time. So patient will feel weakness. Patient appears pale. So there will be increased heart rate can be seen. So there can be palpitation. So this kind of signs and symptoms can be seen with megaloblastic anemia. Now, if you take the peripheral blood smear and observe that under microscope, so you can see a large red blood cells in megaloblastic or macrocytic anemia. You can see that here. So the red blood cells are really larger than the normal, which are called as macrocytes, and also they are oval in shape. So this particular cell here is oval in shape. So ovalomacrocytosis here. And also if you look at the figure here, so there are difference in the sizes, although they are big, but they are different in sizes. This is called as anisocytosis. And also there can be a difference in the shape of each of these large red blood cells, and that is called as poikilocytosis. So this is another feature that you see in megaloblastic anemia, anisocytosis. Anisocytosis, that is difference in the size of red blood cell, and also there can be poikilocytosis. Poikilocytosis is difference in the shape of red blood cell. One of the characteristic feature that you should look for in megaloblastic anemia, and that is considered to be most sensitive and most specific feature of megaloblastic anemia, is you need to look at the neutrophils. This is the neutrophil here, and neutrophils will have multi-segment, hypersegmentation of the neutrophils here, hypersegmented lobules, or the hypersegmented lobes that are present in the neutrophil. Up to around 6 lobes can be seen in the neutrophil. This is considered to be most sensitive and most specific peripheral blood smear marker for megaloblastic anemia. So look for macrocytes, look for anisocytosis, poikilocytosis, and don't miss to look for hypersegmented neutrophils. One of the most important finding there. Coming to the neurological signs that are seen in this kind of anemia. So the neurological signs are seen only with the cobalamin deficiency. Cobalamin deficiency will show neurological signs, whereas folate deficiency do not show neurological signs. This is the major difference here in terms of signs and symptoms between folate and cobalamin deficiency. Folate deficiency, for unknown reasons, so it doesn't show neurological signs, whereas cobalamin deficiency will show neurological signs. Especially patient will have decreased sensation in his lower limbs and upper limbs. So it means there will be pins and needles sensation will be present, decreased sensation to the touch, temperature, vibratory sense will be decrease in the vibratory sense, and also there can be decrease in the reflexes can be decreased, and patient may have weakness in the limbs. And also progressively, so this can lead to patient may be confused, not able to take a judgment properly, and can give rise to later dementia. Now, why the neurological signs are seen in cobalamin deficiency? And that is because of increased neurodegeneration process. Increased neurodegeneration process can be seen in cobalamin deficiency, and especially the spinal nerves, especially in the spinal cord, posterior column, posterior and lateral column is the one which is most commonly affected in cobalamin deficiency, and that we put it as severe subacute combined degeneration of spinal cord. Subacute combined degeneration of spinal cord is seen in cobalamin deficiency, especially in the spinal column, posterior column and the lateral columns are affected. Okay, so why the neurological signs in cobalamin deficiency? So it is because one of the reasons for this is sufficient regeneration of methionine into S-adenosyl methionine will be decreased in S-adenosyl methionine, and this in cobalamin deficiency, and this S-adenosyl methionine is needed for myelination process. And also in cobalamin deficiency, there will be accumulation of methylmalonic acid or methylmalonate. Why there is a methylmalonic acid being accumulated in cobalamin deficiency? It's because deoxyadenosine cobalamin, it is needed by an enzyme called methylmalonyl-CoA mutase. So this methylmalonyl-CoA mutase needs deoxyadenosine cobalamin, and deoxyadenosine cobalamin, if it is deficient, so methylmalonyl-CoA mutase won't be able to convert methylmalonyl-CoA into succinyl-CoA. So methylmalonyl-CoA builds up, and this methylmalonyl-CoA is hydrolyzed into methylmalonic acid, and this methylmalonic acid builds up, and that can lead to neurodegeneration, and it interferes with the neuronal function. So decreased availability of acetylmethionine and increased methylmalonic acid, these are the two reasons why there will be neurological signs in cobalamin deficiency. Whereas in folate deficiency, if the cobalamin is available plenty and if there is a folate deficiency, so you don't really see deficiency of acetylmethionine and methylmalonic acid. So that is why this is one of the reasoning that has been proposed to say that there is neurological signs are seen in cobalamin deficiency but not seen in folate deficiency. Now let's move on to see laboratory tests that can distinguish or differentiate between cobalamin and folate deficiency. So in the laboratory test, so we do serum cobalamin estimation, serum B12 estimation. So if the cobalamin deficiency is there, so you will see deficiency of cobalamin there. So we will do serum folate, serum and RBC folate estimation. Serum and RBC folate estimation can be done. And we can do CBC, that is complete blood count. So in complete blood count, you can see there is increased MCV, there will be increased, that is mean corpuscular volume will be increased, decreased hemoglobin content. WBC count will be decreased, platelet count will also be decreased here. And also peripheral blood smear will show increase in the size of RBCs, difference in the shape of RBCs, and difference in the sizes of the RBC, and hypersegmented neutrophils, which is one of the most sensitive and specific marker. Now coming with the other tests, like we can do estimation, we can estimate anti-intrinsic factor antibody. Intrinsic factor antibodies can be estimated, and we can estimate parietal cell antibodies, which can be seen in pernicious anemia. Parietal cell antibodies can be estimated, and we can estimate homocysteine levels in the blood. Of course, homocysteine levels will be elevated both in cobalamin and folate deficiency. We can estimate methylmalonic acid. Methylmalonic acid can be estimated in the blood. So methylmalonic acid will be elevated in cobalamin deficiency, but you don't see that in folate deficiency. And we can also do Schilling test. Schilling's test, nowadays we don't do this. Schilling test is basically radio-labeled cobalamin will be given orally, and cobalamin injection will be given an hour after radio-labeled cobalamin is given. So in patients having a defect in the absorption of cobalamin in gastrointestinal tract, so they will excrete less amount of radio-labeled cobalamin in the urine. So this test is of historical importance. So we don't generally do this test nowadays, because the reason for this is if we have this serum cobalamin estimation directly, and also we can empirically give vitamin B12 injection since it is a water soluble vitamin. So even if there is no deficiency, it is not going to cause any harm to the patient. So these are some of the tests. Let's quickly revise laboratory tests to differentiate between folate and cobalamin deficient megaloblastic anemia. So serum cobalamin in cobalamin deficiency will be decreased, whereas in folate deficiency it will be normal. So because there will be deficiency of folate there. Serum and RBC folate, so it will be normal in cobalamin because it's not a cobalamin deficiency, it is a folate deficiency. So that will be decreased here, this side, serum cobalamin and RBC. Folate will be fine there. So whereas cobalamin, it will be normal. Complete blood count, so in both the cobalamin and folate deficiency, so you will see megaloblastic picture. Megaloblastic picture, both the or any other signs like is decrease in white blood count, platelet count, and increase in MCV you can see in both cobalamin and folate deficiency. Methylmalonic acid level will be decreased in cobalamin deficiency, whereas in folate deficiency it is normal. Serum homocysteine level will be decreased both in cobalamin and folate deficiency. Serum intrinsic factor antibody can be seen in cobalamin deficiency if that is the cause, whereas you don't see that in folate deficiency. Serum antiparietal cell antibodies can be seen in cobalamin deficiency. If that is the cause, folate deficiency, you don't see it. And Schilling test, we do that in cobalamin deficiency and we don't do Schilling test in folate deficiency. Overall, Schilling test is of historical importance. So this is all about some of the points related to cobalamin and folate storage, causes for deficiency, signs and symptoms that you see in both the deficiency, cobalamin and folate deficiency, and what are the tests that we do to differentiate folate and cobalamin deficiency leading to megaloblastic anemia. I hope this video has made some of your confusions or some of the things clear for you. Thanks for watching as always, and take care, and see you in